Over the course of the past few years, there has been major advances in APL, where the combination of arsenic and ATRA leads to the cure and very high rates of cure in this patient population. However, there's still two areas of unmet need. Number one, in patients with high-risk APL, we still use anthracycline as part of the induction regimen. I think with latest publications about substituting anthracycline with Gemtuzumab, Ozogamicin, makes much more sense, especially if the patient is younger, who will potentially live longer. Exposing them to anthracycline might lead to the exposing them to anthracycline might lead to the emergence of other leukemias or other hematologic malignancies. And by substituting anthracycline with Gemtuzumab, we can prevent that from happening. Particularly that the outcomes remains almost the same when you compare the patients who received ATRA, arsenic, anthracycline with the patients who received ATRA, arsenic, and Gemtuzumab. Another area that I'm very excited about is the oral arsenic. For now, we still use intravenous arsenic in the United States, and there's trials undergoing to evaluate oral arsenic as a substitute for the intravenous form. And that would be very exciting because it would save the patient from coming quite often to the infusion center in order to receive their chemotherapy. So potentially in the near future, the combination of oral ATRA and oral arsenic would be by itself sufficient to cure those patients in the outpatient setting. One more area of unmet need in this patient population is the very high risk of bleeding upon disease diagnosis, because the disease itself induces vascular injury, as well as the disease itself induces homeostatic imbalance, which leads to high risk of bleeding. So we still have so much work to be done in order to overcome that bleeding risk that comes with the diagnosis of this disease. One last thing is early identification of this disease is of prime importance, because the earlier you identify that it is APL, the better chances that you're going to cure your patients as soon as you start ATRA. The more delay in this to start ATRA in this patient population, we put our patients at risk of severe outcomes and higher morbidity and mortality. So education about this disease, especially in the community setting, where those patients might be presenting as first presentation before they come to an academic center, is very important, and to start ATRA as soon as possible.